All right, good morning, class. Sorry this is coming to you a day late. I was not feeling well yesterday. So today we're going to talk about environmental hazards and surgical services. So this is our Unit 3 discussion. So this week we are going to be talking about all the different hazards that can occur in the OR. There are quite a few things that we need to be aware of as far as environmental hazards, stuff like that, physical hazards, chemical hazards. A lot of things like that are pretty risky for us and the patient. So we also have these objectives that pretty much apply to every week. So here are your assignments for Unit 3. Again, make sure you're getting your Unit 3 discussion, your very first post in on Wednesday, and then that gives you plenty of time to make your post to 2, make sure you're getting 2 other classmates. That way you get full credit. That's the thing I'm noticing most. Most of you are doing really well with, answering the prompted questions, analyzing it, putting it in your own words. The thing that I'm having to take points off for is not responding to your peers, and that can dock your points pretty good. So make sure you're responding appropriately to those. All right, so let's first talk about what happens if there's a fire inside the operating room. A lot of people don't necessarily consider this. Normal people, day to day don't consider what happens if there's a fire in the operating room, but it is a very real hazard and it does happen. I have seen it happen just one time in my years of scrubbing. Thankfully, it wasn't very big. It was relatively contained pretty quickly. So I'll talk about that here in a little bit. So what do you do if there's a fire in the operating room? First, there are 3 things that you have to do immediately to protect the patient. This is assuming there's a patient in the room. If there's no patient, there are some other steps that we could take. First, you want to shut off the flow of gases to the airway, assuming the patient is intubated. That will make it worse. We'll talk about the fire triangle here in a bit. Then you want to remove any burning objects from the surgical site that get it off of that patient. And then you want to assess the patient for injury and respond appropriately. Okay. So before we get into what causes those fires, let's manage the risks. What type of risks are we talking about? First, you have to have knowledge of the risk. That's what we're going to talk about today. What are those risks? Okay. If you know what the risks are, then you can have a plan of action. How do we mitigate those risks? How do we continue to monitor for those risks? And a lot of operating rooms now, a part of the timeout procedure where we, at the beginning of the case, we'll stop and pause. We'll talk about who the patient is, their birth date, any allergies they might have, those types of things. They'll also include a fire risk assessment in that timeout procedure, which I think is a really good addition to the timeout. That didn't used to happen when I was, a brand new scrub many years ago. They didn't talk about that. Even in some of our clinical sites now that I take my students to locally, they have a huge poster in every OR that is a fire safety checklist because they're really starting to crack down on this stuff because it is a very real concern and hazard. So what are the types of hazards? There are technical hazards like your electrical equipment. You have chemical hazards that could cause a chemical burn or could treat or cause other chemical reactions. And then biological are going to be things like your diseases, your bacteria, pathogens, etc. We'll talk more about those in sharp safety. That's usually where we talk about those types of hazards. So what is a risk? It's the statistical probability of a harmful event. And we want to make sure that we are taking actions to prevent those risks. There's a whole group in the hospital that is part of risk management. So anytime that something does happen, we have to write up a report, an incident report, and it'll get sent to them, and they'll look at those risks to see, okay, what went wrong? What could we have done differently? And what can we do in the future to prevent those risks? And then they may implement some new rules or maybe something like that fire safety timeout. That's probably where that came from. So here's the fire triangle. It's important to understand this. Okay, I know we're not firefighters, right? But we are responsible for putting out fires if they do occur in the OR, right? We can't just wait for a fireman to show up. We have to take action. So the fire triangle consists of these 3 things. And without any one of these, there is no fire. So if you can mitigate one of the three, the likelihood of a fire diminishes greatly, right? So you have to have fuel to have a fire. So the fuel, and I listed these pertinent to the OR, are things like drapes, even hair. I know that's kind of morbid to think about, but hair does catch on fire. Non-metal airways. And we'll talk about the use of particular types of airways when we're working in that area later. Prep solutions, especially alcohol-based ones, are far more likely to catch on fire. And then even intestinal gases, it's not something, you typically think about unless you're watching some MTV show that I won't name, okay, that it can catch on fire. So the other one is oxygen. No, normal room air that we breathe now only actually has about 21% oxygen. And the oxygen that we sometimes put directly on the patient's face is just pure, like pure oxygen. They need that oxygen at a higher level, okay? So the oxygen concentration in the face area is going to be much higher. We call that an oxygen-rich environment, okay? The third one is heat, or you'll see sometimes this one called ignition, depending on the triangle that you see, but it means the same thing. So the heat sources are going to be your ESU, which is your bovie, your handheld bovie. Could be a laser. It could be the end of a fiber optic light cord. So if we're doing a laparoscopic procedure where we have to take that camera, that scope into the abdomen, we have to have some way to illuminate the inside, right? So we have to hook up a fiber optic light cord that screws onto the scope itself to go into the abdomen. Now, if you hook that scope or that cord up to the machine and then lay the end of the light cord on the drape before it gets screwed onto the scope itself, the end of that fiber optic light cord can burn a hole in the drape very quickly, even if it's on standby. So never hook it up to the machine and then just lay it on the drape. It can burn a hole very quickly. I've seen it happen, okay? Now, if you've hooked it up to the scope, I would prop the scope up in some way that the end of the scope isn't on the drape either, because it can still burn a hole that way as well. And so, in the case if the surgeon takes the scope out and lays it down on the drape, it's your responsibility to make sure that that end of the scope doesn't get put on the drape. Be very careful about that, okay? The other one is faulty electrical equipment. It can happen. Sometimes you can't predict when that's going to happen, but always just be sure that you're checking like the wires aren't frayed or they haven't been crimped or pulled out of its, where it is attached. Always look for those types of things. Okay, so let's focus on the prep solutions. Like I said, the alcohol-based ones are going to be most likely to cause a fire if those other two parts of the triangle are there. Specifically, we focus a lot on ChloraPrep, which is a brand, okay? They come in this little pre-packaged stick in a variety of sizes. They are alcohol-based, okay? So this type of prep solution just gets put on the patient and doesn't get wiped off. That's how it works. It's an antimicrobial and it will last. So you don't want to wipe it off and get rid of that antimicrobial property. So, excuse me, we don't ever wipe it off before we do surgery, even after. We usually just leave it on the patient. But you want to make sure that it doesn't pool. What I mean by that, you don't leave large amounts of fluid, cupped somewhere, especially like the belly button or down the sides laterally of the patient, maybe between the patient and the bed. That's where you're most likely to see it pool. Now, if you were to just prep with this, slap some drapes on, and then start with the bovie, you're going to catch it on fire, okay? So a lot of surgeons and circulators are very particular. They'll use this and actually set an OR timer for 3 minutes. And then after that, they will drape. You can't rush this. If you see a surgeon or somebody trying to rush this procedure, you need to speak up and say something. Don't be afraid to speak up and say something because this is a big cause of OR fires. Okay, so these are two important acronyms. When we're talking about fire safety in the OR, you'll hear this a lot. You need to memorize these. You have pull and race. So race is referring to what you do if you find a fire, okay? Once you find the fire, then you might have to contain it, and you can do that with a fire extinguisher. To remember how to use a fire extinguisher, you need to remember the acronym PASS, okay? So RACE stands for Rescue, Alarm, Contain, and Extinguish. So first, we're going to worry about our patients or anybody in the area. We want to make sure they're safe and get them out of there. The next is alarm. Sometimes I've also heard activate because you're activating a fire alarm. And then C is contain. You want to contain it by, especially in the OR, we have those fire-proof doors. Close those doors off. If it's small enough, you can then extinguish. If it's a raging fire, obviously a fire extinguisher is not going to work. So extinguish for small fires. Okay, make sure you're calling at this point the fire department. All right, and then if you are going to use the fire extinguisher, you have to pull, aim, squeeze, and sweep. So you pull there's a little latch, a plastic piece that you pull out. Then you can aim it at the base of the fire. That's key, okay? At the base of the fire, not the top, the base. And then you're going to squeeze the trigger while still pointing at the base. And then you're going to sweep it back and forth across the base, okay? Until you've run out of the fire extinguisher. Another hazard you'll find in the OR pretty often, even though you can't see this one, is ionizing radiation. So that's basically your X-ray machine. So this picture here is one of a C-arm. A C-arm is a portable type of fluoroscopy or X-ray that we bring into the OR that allows us to get a real live time picture of structures within the body. So we can use it with contrast media to go into vessels. We can see how the blood flows through the vessel. We can do it in cystoscopy procedures to see if there are any stones in the ureters or bladder or kidneys. We can use it in orthopedics to see if we've got that bone aligned correctly before we put in any plates or screws or cast padding, whatever. Also very common in neuro procedures. If we're going to be doing spine cases or whatever, we want to make sure we can see the bone where we're going to be putting in those rods or screws. So it's a very useful tool, but it does come with its risks. Those risks that you can't see are going to be tissue damage to anybody within a 6-foot radius, including the patient. So we do want to limit their time exposed to fluoro or ionizing radiation. The tissue damage is typically going to be to the thyroid and the reproductive organs. Those are the two most susceptible to taking on that damage, which later down the years after, a lot of exposure could lead to cancer of those areas. So how do we prevent that damage? It's important to remember time, distance, and shielding. The amount of time you're exposed, we want to limit. Distance, we want to stay at least 6 feet away from the machine as it's being used. And then shielding is going to be your lead aprons. Yes, they're very heavy. Sometimes they're a pain to wear during a case, but it is important for you to do that. We also have a lead apron that goes over the thyroid. It's just smaller, that will protect your thyroid if you still have one. Okay, some fire risk management strategies. So how do we prevent some of these fires within the OR? Okay, we talked about, some of the things that could potentially cause it. How do we prevent that? There are a lot, actually, and this is just some of them. If I put them all on the page, it would cover the whole page. But these are some of the most common ones. You want to keep the bovie in the holster when not in use, okay? If the surgeon is using that bovie a lot, whenever they lay that bovie down, put it in the holster. Never throw that holster away. It needs to be attached to the drapes in an easy to reach position that allows the surgeon to get that out of there pretty easily. What can happen is if you leave the bovie out of the holster and on the drape, sometimes surgeons are trying to move around to see, they might inadvertently put their arm on the bovie and activate those buttons and burn a hole in the drape really quickly. I've seen it happen. So that's on you. Okay, that could fall back to you as negligence because to watch for that and put that back in the holster. Okay. You also want to keep the bovie tip clean of something called eschar, which is after you use the bovie a lot and it burns through the tissue. Sometimes the tissue can get built up on the tip of the bovie, that's eschar, that burnt tissue. So if you're using like a non-coated bovie tip, which some places still use, you'll need a bovie tip cleaner, little cleaner pad. It's kind of rough. Otherwise, you can keep it clean with like a lap pad or a towel or something. Just wipe that bovie tip off. Otherwise, you can start a spark. You always want to have saline or sterile water in the field. I've seen so many surge techs tell their circulator they didn't want saline because they didn't think they needed it for the case. But, what if you do start a fire on the drapes? What are you going to put it out with really quickly? If you have that saline or sterile water in the field, all you need to do is grab it from your back table and throw it on the fire, and that usually mitigates it. So I always take that. Some people I think are just lazy and they don't want to have to clean up the sterile water later or suck it up or whatever. It's like an easy step, and it's a good way to manage fires if there is one. Again, don't place fiber optic cord tips on the drape. Talked about that. And always let all prep solutions dry. Okay, now what about lasers? We haven't talked about lasers yet. So not all cases will use a laser, and there are actually a lot of types of different lasers, but they all have the same basic risk strategies that we're trying to mitigate here. Lasers are like a long, very small, thin, like cord, so to speak. It's not really a cord, but the tip on it is what's the usable end that could be used to cut tissue. It could be used to like break up a stone in the kidneys. It does have a lot of important uses, but you want to keep that laser on standby when not in use. So a lot of our places have a special not lazy, they're not lazy, a laser safety person that will take care of this, that they operate that laser machine. We have to be specially trained to do that. Not anybody can just operate the lasers. So they keep that on standby when the surgeon is not using it. That helps prevent. You want to place wet towels around the operative site. So let's say we're lasering off some genital warts, which happens. Okay, so we'll put a lot of wet towels around the perineal area to prevent any type of fire. You again always have saline or sterile water. And then if we're in the airway area, face, airway, head, neck, ear, and we're using laser, anesthesia will use a laser specific ET tube that will not like melt or catch on fire if the laser does accidentally come in contact with the tube. Now, I didn't put any pictures on here, but you can easily look for these of airway fires. Okay, what essentially happens is because of the oxygen-rich area, the laser will catch the tube on fire and essentially burn the patient's lungs from the inside out. And it's usually, in that case, with an airway fire is deadly. So it is very serious, and we want to make sure we're taking all risks that are all management safety risks that we can. And again, have the correct fire extinguishers available. I did put some of those on here. So there are a lot of different types of fire extinguishers. Sometimes it's a little hard to remember, what you can use on what. Our laser cart comes with the correct fire extinguisher already there and ready. So they're sometimes lettered based on what they can be used on. K, for some reason, K always sticks with me because K is for kitchen fires, KK. That's easy, okay? And then you've got these other very specific, what is in the canister types of fire extinguishers. So it's important to know what you can use it on and also what you cannot use it on. Okay? And it'll tell you right on the extinguisher. Another really important hazard that you're going to encounter as a surge tech is something called the surgical smoke plume. The plume is what comes off the smoke of the bovie that is burning tissue. It is one of the most, you get used to the smell, but it can be pretty hard to get used to as a student to smell like basically burning tissue, right? But it is used in 95% of procedures. A lot of surgeries will use some sort of electrocautery device, but look at this alarming statistic. Says daily exposure to surgical plume equates to smoking 27 to 30 cigarettes a day. Now, even if you're a smoker, I would venture that you don't smoke 30 cigarettes a day. Maybe you do. I doubt it. But that's a lot. That is going to cause some damage to your lungs very quickly. The incidence of lung cancer in surge techs and surgeons are actually shockingly high for this reason. And maybe it's not shocking, but to other people it is. So anybody in the room, even if it's the circulator who's sitting further away at the desk, is still being affected by this. Not maybe as much, but it is affecting them. Okay. So now that this is kind of becoming more of an awareness in a lot of places, they're implementing different standards to try to mitigate this, which is sucking up that smoke plume. And there are special smoke evacuators that a lot of places will make you use now to get rid of that plume. And some of them are even attached to the bovie itself. Sucks up that smoke plume, gets rid of it before you have to even inhale it. So here's a quick little video about the dangers of the smoke plume that I wanted to show you because he goes into some good detail. This is courtesy of Surgical Tech Tips. If you haven't checked out this YouTube video, I would recommend it. There's a ton of good little nuggets of information from this guy. So
we all know and understand the problems associated with smoke inhalation. But what about surgical smoke? Stay tuned. Surgical smoke, or plume, can be a pretty dangerous byproduct of energy device usage in the OR, day in and day out. Some examples could be monopolar, bipolar, and lasers. There's a multitude of other energy devices that we use in the OR that produce this plume, this surgical smoke. The most common one will probably be the bovie. It's just monopolar cauterization. We use it day in and day out, pretty much on every single case that enters an operating room. And I'd have to say the monopolar cautery and laser usage probably produce the most amount of smoke in the operating room. Now, during surgery, plume can be pretty annoying, not only to the surgeons, but the assistants and the techs, residents, anybody that's really standing up at the field. The odor can be pretty bad at times. It stinks. But even more so than that, it can be pretty obstructing as far as viewing the tissue that you're actually working on. To be more specific, like lap choles, many surgeons that I've worked with in the past have used like a spatula monopolar cautery when taking down the gallbladder. And a lot of these surgeons are just so fast. I mean, some of these cases only take like 20 minutes, but you know, they have a grasper in there, they're holding the gallbladder, and they're just monopolar bovie all the way up the back side of that gallbladder, taking it off the liver. And they're doing it so fast that there's just, the whole abdomen is like full of smoke, and it's like you can barely see what you're doing. I don't know how they do it sometimes, but it's important to have some things in place, especially on laparoscopic cases, to evacuate that smoke in a quick fashion so that they are able to keep a good visualization of the tissue they're working on. So who's at risk? Obviously everybody that's standing at the field. You and I are standing at the field. A surgeon, a resident, a nurse, whoever is standing at the field right there in the middle of surgery is at potential risk of inhaling, you know, these vapors, this plume. It's been shown that plume can contain toxic gases, vapors, viruses, bacteria. Probably an example of one of the most important cases for you to wear proper attire would be like an HPV patient and you're burning off like genital warts or something like that. It can be used with either monopolar or lasers, but the smoke produced from burning off those genital warts could transmit to other people in the room if you're not using the proper smoke evacuation and if you're not using the proper mask and attire for the case. So, how do we prevent these hazards? Because these hazards are easily.
I want to pause it right there real quick just to input a little story there. So we had a surgeon that would refuse to use like a special smoke mask that filters out more particulates than a normal surgical mask. When we did these genital warts case, we would burn them off with a CO2 laser. And since he didn't want to wear that surgical mask, I would wear like two of them. I don't want that. He would actually get the HPV virus in his nose, and he would have to have them cut out of his nose once they grew. I don't know why he refused to wear that mask, but that always stuck with me because this guy is right. You know, in this plume, it's not just smoke, it is burning tissue, it's live tissue, live viruses, bacteria in that plume that you are breathing in. Okay. So that is a huge danger. So always take, any step you can to prevent that. You also want to suction within 1 centimeter of that smoke area where he's burning with that laser to prevent that from even getting up to your face. I just wanted to input that real quick.
Easily preventable. Number one, use your suction. Every case that you're going to be working in, or that you are working in, has use of suction on the table. It's usually just a suction tubing and a Yankauer tip or whatever type of suction tip you're using. If the surgeon is working and burning through tissue, you have that suction nearby that incision, just sucking up that extra tissue smoke, that plume, so nobody at the table has to breathe in all of that vapor. Number two would be use a smoke evacuator. On those specific cases like HPV patients where you're burning off some genital warts and stuff like that, we have specific smoke evacuation machines, and some suction machines actually have smoke evacuation settings to them. But you can use that to help even more with getting that smoke out of the field and not in anybody's faces. Number three, make sure your hospital has some sort of hazard markings that they utilize on their surgical schedules, just so the people that are working in that room know and understand that there is a hazard that is associated with this patient that they will be working on. Number four, if you are in a hazardous case, use an N95 respirator mask. Everyone calls them TB masks, tuberculosis masks, but they're not only just used for TB patients. Use them on those HPV patients if you're going to be doing a wart removal. Put that mask on. I know it's hard to breathe through those masks and it's a pain in the butt, but you are preventing yourself from a potential hazard. You're doing it for yourself. Now, all that being said, I know tissue smoke and surgical smoke is nowhere near as harmful as like cigarette smoke. It's like 95 or 96% water. So, surgical smoke is essentially like a vapor because, our bodies are made up of that much water. So just cutting through tissue, you're basically cutting through water mostly. But I just want people to recognize the hazards, the potential hazards that could happen in the OR, depending on the cases that you see. So I hope you guys liked the video. If you did, please give it a share and a like, and I will see you guys in the next one. Bye.
Hopefully that video was helpful to you. There is a lot more that we could talk about with the smoke plume and really the dangers. I mean, he is right, it is mostly water, but it's, the viruses and the bacteria, the tissue that you are breathing in that becomes very dangerous. So we'll take that into consideration. So if you guys have any questions for me, please feel free to reach out. I know some of you have, which is great. I love hearing from you guys. You guys are doing a great job so far. So keep up the good work. Feel free to reach out to me. I know this is airing on Wednesday now instead of Tuesday, but if you need to get a hold of me, we can work something out if you need to. All right. Hope you guys have a great rest of your week. Bye.